How is everyone doing today? Good, fantastic. Have you been walking around, seeing the sights, enjoying the spectacles on offer today? Fantastic, thank you very much there, responsive audience member. Good afternoon and welcome to the Great Exhibition Road Festival's Trailblazers Talks. In this grand lecture, we're about to celebrate ideas, technologies, and individuals that have contributed to our modern world and or could influence its future. This first session takes us inside the operating theatre of tomorrow with a look at the future of surgery. For this, we're delighted to be joined by Lord Ara Darzi, Professor of Surgery and co-director of the Institute of Global Health Innovation, together with the members of the Hamlyn Centre for Robotic Surgery at Imperial College London. Today, they'll be taking us both backwards and forwards in time with historical stories of breakthroughs in surgical innovation, before looking to the future with some of today's trailblazing innovations that will fundamentally change how surgery is carried out. So I've said welcome to the audience here as well. I'd like to say hello to the audience at home. We've not forgotten about you. We're so happy that you're here as well. So if that's okay with everybody, let's get started, and I'll hand over to Lord Darzi and the team. Thank you.
Thank you for that wonderful introduction. Good morning, everyone, or good afternoon now. Welcome to the Royal Geographical Society. Ara Darzi is my name. When I grew up, I wanted to be an astronaut, but I miserably failed. So sadly, you're going to get a surgical talk today. A surgical talk from a multidisciplinary group. One thing I'm going to be addressing and certainly re-emphasizing is innovation in this time is all done through different groups from different disciplines coming together to create new value. And in this case, it's going to be how do we create new value in surgery so we can treat our patients in the highest quality way, in the most minimally invasive approach, and the quicker and the best recovery you could achieve. As I was introduced, I am a co-director of the Hamlyn Centre, and that Hamlyn Centre is a centre at Imperial that brought in the physicians, the clinicians from the Faculty of Medicine, the engineers, the top scientists from the Faculty of Engineering to work together in a single centre to create that interdisciplinary work. So, surgery. Let me start with the first slide. John Hunter is the father of surgery, not just in this country, by the way, the father of surgery across the globe. He was one of the first visionaries of his time that combined the art of anatomy, and anatomy was an art in those days, dissection, identifying and naming muscles, blood vessels, nerves, organs, was very much part of what Hunter did. And if any of you would wish to visit the Royal College of Surgeons in Lincoln's Inn Fields, there is the Hunterian Museums. There are all his wonderful specimens that he used to teach, and also himself, as he admitted, to learn from. But despite that, Hunter made a very powerful statement in those days, because surgery in his day was what he described as an armed savage who attended to get that by force. In other words, removing organs by force, which any civilized man would get by strength. And that quotation is a critical one. You have to remember, in Hunter's days, you did surgery without an anesthetic. So you had to be quick. It took seconds to remove something because no one would have tolerated the pain on the operating table. So it was mutilating surgery in those days. But what was unique about Hunter, he thought about bringing the anatomy with the biology and the physiology. He was one of the first to think of the consequences of removing an organ and what is the physiological deficit to that patient. So that was the early thinking, and that would have been in the 1700s. This is an example of a mastectomy in those days. A patient with a breast cancer, and you can see the patient is being held not by an anaesthetist, but probably 3 or 4 security people, big build people, holding the patient. And that's the surgeon using a device, a very crude instrument, which is a heating instrument, to essentially destroy the local breast cancer tissue. Incomplete, mutilating, with terrible outcomes. That was surgery again in 1700s. That followed by a century later, nearly 1850s and 1860s, that there were 4 disparate groups of scientists working in different parts of the world. And the reason I'm suggesting this to you, because intermittently you get scientific discovery in different parts of the country or in the world that come together to lead, which led at the time to the creation or the giving birth to modern surgery as we knew it, certainly as I knew it during my training days. The first of those was Morton. This is in the MGH, which is the Mass General Hospital in Boston, which I have visited. I've actually given a lecture in that room. MGH, just to give you the funny side of it, those who work in MGH describe it as man's greatest hospital is what it stands for. It's not actually, it's Mass General Hospital, but they describe it themselves as man's greater hospital because Morton discovered anesthesia. And you can see there, he's using a bit of ether around the face of the patient, highly inflammable and toxic chemical, but put the patient to sleep. But you had to be careful because if you weren't careful, you can get an explosion and burn not just the patient and the surgeons and everyone else in the operating theater. The second was Virchow. Now, Virchow is another clever guy because he decided, well, we're taking these things out, but what's wrong with the patient? What is wrong with the organ that we're removing? And he led to discover what we call pathology. In other words, understanding what is the disease you're removing. You're removing an organ like a kidney. You want to know what is it that has caused the disease in the kidney. Is it a stone? Is it an infection? Is it a tumor? So Virchow mastered the art of pathology and understanding disease. This guy was Billroth. He was an artist, and you can see in the operating theater in Vienna, and Billroth, surrounded by the students and many other people who used to come and watch the master surgeon operating. He designed all the surgical instrumentation and the technique of operating surgery. He was a master actor, absolutely. When you sat in that theater, it was the best show ever. He was the guy who designed the scalpel. He was the guy who designed the scissors, the graspers. And believe it or not, I still use Billroth instruments in my operating theater. They're still around. Probably slightly modified, sharper, but these were the instruments which were used then and we use today. And finally, our own man, who was in King's College, not in Imperial, and that is Lord Lister. He's the guy who came with the analogy that you could do this operation with the instruments, you could have an anesthetic, but a lot of these patients were getting serious infections after surgery. And he introduced what we call the aseptic technique. He was the guy who said, you need to clean the skin before you make the incision. You need to use aseptic techniques inside the operating area you're operating on. Otherwise, the patient is going to get an infection. May I just remind you all, this era was pre-antibiotics. Antibiotics was discovered by Alexander Fleming in 1928. This is mid-18th century. So there were no antibiotics. So if someone got an infection, if they were lucky enough, they could have survived it with their own autoimmune response, your immunity that got you through it, or if you didn't, that was it. You got an infection and you died from the operation. So coming back to my whole concept of convergence, in other words, bringing disciplines together, it was actually the convergence of anesthesia, technique and instrumentation, pathology, and asepsis that led to the birth of modern surgery that we practice today. That took about 2 centuries to get to that point, pre-antibiotics. Interestingly, around that time, there was also a thinking of convergence in the mindsets of leadership of this country. Started with Prince Albert, which came up with the idea that we should have the Great Exhibition on a Great Exhibition road. And by the way, Imperial and many other institutions on this road, including this one, were the beneficiaries of that great exhibition. If my memory recollects right, it was the first exhibition that the United Kingdom has ever held that made money. And that money, at the end of the day, actually endowed many of the institutions on this great famous road, including Imperial. And his philosophy was, we need convergent platforms at the great exhibition. And that is why you have the history, that is why you have the arts, that is why you have technology and engineering, that is why you have the arts, you have the music on this road. He believed then that convergence is the future of science, it is the future of innovation. And that message still stands. Anyone working in silos would not succeed in scientific discovery. So, in this organization, which is Imperial, I'm going to share with you the platform that has completely transformed the way I operate from the day I joined Imperial, would have been in St. Mary's Hospital in Paddington, nearly in early 1990s, to today, which is the convergence of these knowledge bases: chemistry, physics, engineering, mathematics, computer science, life sciences. And you're going to see later demonstration by different people who brought these different knowledge bases and scientific platforms together to achieve the demos that you will be witnessing later. Some of the areas we work in this great center called the Hamlyn Centre: materials and microfabrication. We want new materials that are much more amenable to finer caliber instruments that we can insert to very, very fine hollow organs. Information technology and artificial intelligence, the ability to guide the surgeon looking at an image and potentially put some constraints in the area that they're operating on so they don't go into a normal tissue and do the damage. Navigation, knowing where you are. You do have to remember, surgical navigation was based on your two eyes and you're looking at, but the potential of getting beyond the surface of an organ to lead you to navigate into areas, small areas, is absolutely critical. Biophotonics, spectroscopy, giving you an immediate reading, what you're actually dealing with in terms of a cellular level, and you're going to see a demo of that. Genomics, being able to detect, and other omic platforms that will help you and guide you. And I'm going to show you something about how we use omics, which is this metabolic signature of tissue to guide breast cancer surgery, will be my last example. So this is how Bill Roth started. The best two surgical instruments ever invented in the world is the two human hands. Okay? It has 6, 7, 8 degree freedom of movement. You have sensation, you can feel something. And by training in my whole career, I could recognize what feels soft, probably a benign tumor, what feels hard, stuck, which is a malignant tumor. Best surgical instrument ever designed. And since then, we've been trying to design surgical instruments which are better. So about 25, 30 years ago, this whole concept of keyhole surgery came in. And keyhole surgery make a small incision, insert these instruments, which are 5 millimeters in diameter, in other words, a quarter of my little finger, into these tiny holes to do the procedure. And that was facilitated by a camera, which actual fact was discovered, is the Hopkins rod lens here, by a reader in physics in this institution in 1954. That never translated into human benefit until years and years later. The laparoscopic revolution, or keyhole revolution, happened in late 1980s. Actual fact, started in Lyon by a gynecologist who did a lot of laparoscopy to look at infertility, but he decided to stick 2 further instruments in, not for diagnostic purposes, but to treat someone. And he took the first gallbladder out in 1988. And that was transformational, because everyone looked at what else could we do through the keyhole way. So it was less painful, it was earlier mobilization, fewer infection because you have smaller wounds, short hospital stay, early return to work. This was the biggest disruption I have seen in my own discipline in my working life. Completely changed everything. The patient that I would have done on the right-hand side an operation on to remove simple gallbladder, big incision, couldn't breathe after the operation because of the pain. They would have been in hospital for 1 week. Big scar, wound infection sometimes, clots in their legs because they weren't moving because of the pain. You shifted all of that to the left. Precision, tiny incision, no anesthetic, no painkillers after the operation, out of bed within hours from the anesthetic, having a cup of tea, wanted to go home. In the first few patients, I was terrified. Should we send these guys home? No, stay here until, and it was my own insecurity when these patients were desperate to go home. Since then, we have modified a lot of the endoscopies, and you will see a number of presenters here, whether it's George, Ferdinando, and Dan Elson, and many others who came up with finer scopes that would go into interesting areas to improve the access, to make the access even smaller. Access is the size of the incision. First thing we need to do is access to where we're trying to get to. Second we need to do is to characterize what is it we're looking at. And we can see this is a cellular imaging of the tumor we're looking at. It's not even naked eye. We don't even see these things. These are attaching small scopes, and you can see some of those later. And then finally, new tools in targeting therapy. Because if you can pick up something early, it's tiny and small, instead of removing an organ, you try to remove a few cells or a segment of that disease organ. And this is a wonderful example of robotics which followed keyhole surgery. And this is a piece of work that George was involved in with Eric Mayer and Justin Vale. This is a patient who had a kidney tumor to the upper pole. Instead of, in the old days, we took the whole kidney out for a small tumor at the top end because we had no other way of doing it. Robotically, they're going in there, they're showing the surgeon at the time of surgery where is the tumor, because he can't see, you could only see the surface. They are displaying or augmenting a 3D tumor on top of the area, so the surgeon knows that is where it is, and they cut around it with clear, normal tissue. So no one is going to lose their kidney anymore, they're just going to lose the top end of the kidney where the tumor is. Absolutely transformational. Before, you're left with one kidney, and you worry about it all your life, how to prevent damaging it, because one was removed previously. Here, just remove a segment of the kidney, and that is transformational from a urological perspective. Another example, this is another piece of work. This is an old piece of work. Actual fact, the reason I show this is the first grant we ever got in the Hamlyn Centre from EPSRC and MRC. It used to be called the Hopping Award. Could we have the videos working, if you can? So what we're trying to do here, in robotic surgery, we have a left camera view, right camera view. I don't think this is going to work. I don't think we have the best IT here, but anyhow, I'll try to explain to you. Because you have two eye visions here, we track the surgical eyes who's looking inside the robotic platform. And if you track the eyes, you can measure the convergence point where the individual is focusing. And knowing the tissue characteristics, you can then move the scope at the same speed as the beating heart or in any other organ. In this case, it's the beating heart. When you move the scope at the same pace, you actually see a still image rather than a moving image. Why are we doing that? Because we don't want to stop the heart. One of the biggest disadvantages in open heart surgery, they stop the heart, they paralyze it, and put you in a heart and lung bypass machine. We discovered that that's not very good to recovery or your cognitive ability after the operation. So what we wanted to do with robotic coronary artery bypass graft is to do it keyhole and do it without stopping the heart. So if we move the scope at the same speed as the beating heart, its heart looks to the surgeon as if it stopped. Let me give you another example. I'm sure you've had kids in the back of your car driving on the motorway, two cars together, and suddenly the kids tell you, why did we stop? You haven't stopped. You're moving at the same speed as the car beside you. Have you ever had that feeling? That's exactly what I'm talking about, but during an operation. Again, apologies, these videos didn't work. Oh, there we are. It's starting to work. So that's, we are tracking the eye movements, and then we are tracking, looking at the operative field, and by doing so, you then moving into the beating heart. Anyhow, this other area, which is fascinating also, again, very early days, is we wanted in robotic surgery, that's me, you can see me, I was much younger, I had more hair and certainly darker, operating on the, what we call the master station. And what we're trying to do here is, again, it was George and his team who created areas of safety zone that I could move the instruments in. So I can move beyond that safety cone, and the reason for that, so I don't damage tissue on the side where I'm operating. And that was what we call a force constraint. Imagine being force constraint. I would love to introduce force constraint in Parliament one day to stop these guys doing what they're doing as we speak. So that's what, some of the newer technologies you're going to see today: flexible endoscopy-based systems, rigid single-port systems. In other words, doing an operation through a single port rather than multiple ports. And this is another technology came out of Imperial called the Ice Snake robot, which is a flexible scope. It has 2 instrumentation plus a camera, very different than a colonoscopy. You may have had a colonoscopy or an endoscopy. It looks like that, but these have 2 instruments there, which actually you can use to cut something and at the same time to stitch something at the end of it. So we're not even cutting someone open. We're going through the mouth or through the bottom end or whatever natural orifice there is to get access to that area and remove whatever we have to remove. Another area, you can see the sophisticated instruments here, which these instruments move like a human hand, but they're much finer and much smaller. And then we are able transrectally, which is my area, which is colorectal cancer, go inside the anal canal, find the tumor, excise it as it is, and stitch it up instead of removing the whole organ. So we're removing the tree, but we're not removing the roots and the soil with the tree. And that's another way of approaching very early tumors that we're looking at. Another one is how do we do colonoscopy in operation. This is another side probes, which you may see later. This is the normal endoscope. If you've had a colonoscopy, this is a sheet that goes on top of it. So what you do is, as you go inside the bowel lumen or the stomach, you inflate this balloon, and once you inflate the balloon, which you can see beautifully displayed here, you create space, because this lumen is tiny, it's about this size. You create quite a big space without rupturing it because the pressure is distributed. You have 2 instruments, you do your operation and resection, you stitch it up, and you get out. That is the transformational bit of flexible endoscopy or colonoscopy and gastroscopy that allows you to do surgery in the future. Or you can insert devices like this inside the lumen, automated, that go in and actual fact remove and shave the tumor from the area you're trying to get into. And that's, you can attach it to a scope or you can put it on the scope and get it out there. And it's, again, a technology very much in a lab, but potentially could have a huge application in the future. Some of the other instrumentation materials, imagine using some of these newer materials to create micro catheters and tubes. Why we want to do that? Because we want to go to the tiny branch of the, what we call the bronchus. That's the lung. This is the airways that we breathe through. But if you have a tiny tumor at the periphery, you can't get access to that unless you have a very tiny catheter or a biopsy channel to go either biopsy it or destroy it. So this is one of these graspers, and you can see what it's trying to grasp there on the right-hand side. That structure is 1 hair follicle. It's 1 hair. So you can see the size of your, could be one of your hair, and you can see the size of the instruments. These are tiny and very fine instruments doing surgery in different areas. Finally, finishing off with the omics I talked to you about. What is omic? When we cut into a tissue, there's always a metabolic signature. The smoke that comes up, there is some signature in that. And the whole idea here in breast cancer surgery, which has completely transformed from the first slide, we don't remove all of the breast anymore, we remove the lump. What we want to make sure is that there is a clear, normal tissue around that lump. We're not cutting into the tumor. And in about 30% of these operations, sadly you have to wait for a week to get the pathology report, where the pathologist will tell you you have a clear margin or not a clear margin. So the idea here, working with Professor Nicholson and a huge team again in Imperial, is could we actually, as the surgeon is cutting with this thing called bovie or diathermy, could we suck the smoke and guide the surgeon and say, well, in actual fact, they are cutting through tumor or not. This is an animation. We're looking at liver. That's a small little tumor there. We want to make sure that the excision of the liver is clear on the margins. Otherwise, we're leaving tumor behind. And this is the video. You can see that the smoke is being sucked from the diathermy machine. It goes to another machine in the operating theatre. It's called a mass spectroscopy machine. It analyzes the smoke and the particles. It's analyzing whether there is tumor. It goes red. If there's no tumor, it goes green. We have traffic light system for surgeons because they're not very smart, so they need to just show them you're cutting in the right place or not. So that's another amazing innovation in years to come. So surgery has become much more compact, much more versatile, better access, better vision, better outcomes, thanks to convergence of different platforms, and you're going to see wonderful examples of that in the next few minutes. So thank you for your time. Lovely to see you all. You're living through great times if you ever need surgery.
Right. So we're on to the demos. My name is Ferdinando Rodriguez, and I'm the engineering co-director of the Hamlyn Centre. I'm going to try not to fall on this, share, great proximity with you all. And we have a set of demos that highlight some of the latest technology that are coming our way in the not-too-distant future. Now, I personally have been in this sector for about 20 years, and I have witnessed an enormous speed up of technology developments, thanks to the convergence Ara was talking about. And today, I'm going to show you a little snippet about what we're doing in a specific domain, which is orthopedic technology. And I'll be doing this with Hisham, who's one of our researchers, who recently graduated with a PhD on augmented reality, which is the topic of today's demonstration. Now, what you see up here is instrumentation. And although Ara has demonstrated what is the latest in surgical technology, it is absolutely the case that in operating theaters across the world, the majority of instruments for standard joint replacement, so hips and knees, which many of you will have experience of directly or indirectly, because it's one of the most common surgical procedures, is carried out by the sort of instruments you see up there. We've got acetates, right, for planning and measurement. Okay, I need a big one or a small one. You've got oscillating saws in the bottom right-hand corner. Let me say here. Yeah, we've got screwdrivers and other instrumentation, which is a little bit akin to a workshop, right? So in a sense, while we're pushing the boundaries of surgery, as of today, for many of our colleagues in the operating theater, the instrumentation look a little bit like this. Now, there are many reasons for it, which we don't have time to go through in this demo, but it is certainly the case that technology is trying to come to the rescue. And one of the ways we're trying to improve things, as Ara mentioned, is through computers and robots. And so today, robots exist, right? They look a little bit like the one you see on screen. It's one fairly mature commercial example from a company called Smith & Nephew. It is an instrumented drill that is called a robot because, as you can see from the little video that you just saw, the drill is motorized, not only in the spinning sense, but also going in and out this metal sheath. And so once the computer knows what part of the bone you have to cut and what part of the bone you want to keep, it will retract and push forward this drill in order to help the surgeon machine away with a free hand, but with very, very good control of margins. So what part of the bone stays and what part of the bone goes. And that's where we are at. So that's a commercial system. That was the state of the art a few years ago. If you take this system in a little bit more example, you'll see that there are a few ingredients that, to the lay audience, still look a little bit impractical. For one, it's got a screen. And screens are good if you're sitting in front of a computer and looking at a screen to do your word typing and so on. They're not so good if you are in a cluttered operating theater and you're looking down a minimally invasive incision, which, as Ara suggested, makes things a lot harder, and you have to triangulate with your eyes and your hands to try to interpret what's up on screen to what you're seeing in front of you on the operating table. And that is where technology can come to the rescue. The other amazing thing, which many of the lay people in this audience may be surprised about, is that as of today, in orthopedic robotics, the state-of-the-art commercial robotics uses what Hisham is showing you here, a set of pins that hold markers that are screwed into the bone in order for the machine to know where the limb is. Because clearly, the machine needs to understand where the human is and where the patient is in order to provide assistance. And that is done through a process of registration, which is beyond the purpose of this demo, but it requires some sort of tracking. And the tracking is performed through these markers. Now, they are very accurate, they're very fast, they're very robust. However, as you can see, they require screws to be pushed into the bone, not necessarily in the part of the bone that the surgeon has opened. So it needs an additional stab wound, which you put the screws through, which is not certainly ideal. A bit barbaric, if you ask me, but to this day, the most appropriate way to do the tracking in surgery. And so it is because of these limitations that over the past number of years, with Hisham and other members of our team, we've been looking at technologies to make things better. On the demo today, which as you can see is sort of a mixed demo, because I think streaming what Hisham sees through this sort of live setup in RGS was a little bit taxing, is to take some of the state-of-the-art in sensing technology and bringing it to the operating theater. Specifically, two things, one of which some of the gamers will be aware of, and some that will not. The sensing of the Xbox Kinect, which is depth sensing. It allows you to take measurements of the 3D scene in the form of a point cluster. That is one technology that we're using. And second, this idea of augmented reality. So a screen like what Hisham is showing you, and this is second generation, it's called Hololens. It is still very much a research tool that Microsoft produces and makes available to scientists like us. And it helps you to display augmented reality cues directly on this, in the visual scene of the surgeon. And that has an enormously powerful advantage because it allows you to co-locate the visual cues that the surgeon needs in order to do their surgery directly on the surgical scene when and where required, and only when and where required, as opposed to the screen that requires that additional learning curve and interpretation. So as you can see here, our job here was to take the HoloLens, which already has both of these things, because as you can see here, it has red, green, and blue, and depth information available on board in the headset, and the idea that you can also project visual information directly on the surgical scene, and we brought it into the operating theater. So now, what you can see here, right, is, oh, in fact, let me just do something. Let's just go back. So if we take this demo, that's the system up on the left. What you see here is the tool, which is tracked. This is what the surgeon would use to, for example, identify features on the bone. And this triplet is used to track the bony anatomy. What you have here is the camera, which looks at those markers and triangulate the imposition of all of these bits of the puzzle together, so the system then knows what to tell the surgeon the implant should go. So if we now take all of this away, and I have this very high-tech prop here, imagine a future where the camera is gone and becomes a gilet holder. Where is my thing? That's it. And the tools, sorry, the markers attached to the bone are replaced with nothing, right? So you're no longer having to use a geometrical primitive, so something the system knows how to recognize. So there you go. Oops. Which is what you see here. You no longer need this screwed into the bone with percutaneous fixation. You can actually just look at the scene and interpret it. And that is all possible thanks to the Googles of this world, the ability to do very complicated mining of data that was unconscionable just 5 or 6 years ago. Because now you can basically take a whole wealth of information that you acquire in the lab or in the operating theater and help the computer understand, okay, what you're looking at is bone. What you're looking at is soft tissue. What you're looking at is Hisham. And then slowly but surely, the machine learns how to abstract that information such that, as you can see in this demo here, you can look at a completely unseen scene, like the one you see here on the left, which is a typical lab setup in my laboratory, and identify that what is there in the middle is bone, and what is not red is not bone. And that can be done with no training, no prepping in the operating theater. It can be made robust to occlusion, so if you partially occlude the bone, the system still is able to pick out what is bone within that cluttered scene. And importantly, it can be redeployed if you're changing the camera or looking at a different patient. Now, this, of course, is still in the lab. is not in the world at the moment, but it is a sort of technology that will make its way into surgery in the next 5 to 10 years. The second and more important thing that the system like this allows you to do is that once you know where things are completely seamlessly without the need for that camera, you can, as you can see up on screen, and what Hisham is testing, or is demonstrating. On the left is what a classical setup would be, and on the right is Hisham's PhD, right? Not only his PhD in the sense that we have a whole group of researchers doing pretty much the same thing, but look how amazing the ability to overlay those cues at the right time on the exposed anatomy of the patient is. Now imagine you walk in, no complicated system, no camera, no registration, no additional overhead. You just walk in. You will probably have a headset that looks a lot more streamlined and elegant than what you have here. And that, of course, means that this is frontier research, but at the cusp of being palatable from a clinical translation point of view, to have a system that will eventually show you exactly what you want at the right time. And that's it. That's the demo today. I wouldn't be surprised if Hisham was poached by one of the big companies that are currently trying really hard to translate some of this research to industry. And then in the 5, 10 years from now, you probably have some of this in the operating theater. So thank you. And then on to George. Thank you.
Many thanks, Ferdi. Thanks for the introduction, and thanks, Professor Darzi, for a very nice overview of where surgery started from and where it's going. And I'm very happy he also showed some of the projects I've been involved from the get-going of my involvement with Imperial College. So today, I want to say a few words about one line of research we're doing within my group, which is related to how we use what we call perceptual docking. Basically, we're using perceptual information from the human being. When I say perceptual information, what's that? That's, for example, information we can collect through our visual system. You know that our eyes are there to tell us what's happening around the world. They're there to collect information, actually eager to collect information. I look around to see who's here, how many people, what kind of clothes you're wearing, what is your age group. So my eyes are like darting around all the time to collect information. But also at the same time, the human visual system is doing something else. It's projecting information to the outside world. Think what we say, the eyes are the window to the soul, to the brain, to the mind. We actually, if we're able to track the information from a human visual system, we can provide this kind of bidirectional collection of information that can help us to improve surgery. And today, with the help of my postdoctoral research fellow, Adrian, and a PhD student, Kaitze, we're going to show you a very simple example of how we use information from the human visual system by means of a technology which is called eye tracking. And unfortunately, this is a very simple demo we're going to show you today because that's all we can do. It's very difficult to move certain equipment across from the labs. But nevertheless, I think it's impressive, and it will get you to appreciate this line of research, the perceptually docked surgery. So to start with, perhaps is a good point, a good time to play a video on the screen. It will give you an overview of surgery, pretty much close to what Professor Darzi has shown already. And then we will be able to talk you through and show you the video. And what is it? Oh, yeah, it's a clicker. Thank you. All right.
Did you know that on average during your lifetime, you will have 9 surgical procedures? Fortunately, there's never been a better time in history to have surgery, and while we cannot eliminate the possibility of things going wrong, we can trust that patient safety is always going to be the #1 priority. But that hasn't always been the case. We've come a long way since the earliest recorded accounts of surgical procedures taking place, back when the chances of survival, let alone recovery from it, were pretty slim. In the Victorian era, procedures were so gruesome, tickets were often sold to spectators. For surgeons back then, the larger the incision and the more blood on your apron, the more respected you were. For patients, this meant that if they survived the experimental procedures, they faced long, painful, and uncertain roads to recovery. Thanks to people like John Hunter, a Fellow of the Royal Society and an advocate of careful observation and scientific method in medicine, surgery transformed from risky art into a scientific discipline capable of treating many diseases and conditions. And while large incisions are still a feature of modern-day practices, particularly in open surgery, surgeons have adopted a more sympathetic stance toward patients. In the 1980s, we saw the introduction of less invasive techniques like laparoscopic or keyhole surgery, which involves making 3 small incisions on the patient's skin. The technique is far less traumatic for the patient, but can take a long time to master. Fast forward to the late 90s, and we see the introduction of robots to help make surgeons' lives a bit easier. While these surgical robots were still being controlled by a human operator, they could accurately replicate the surgeon's actions, so complex tasks became more manageable. What's more, robots enabled surgeons to do things that couldn't previously be achieved by a human hand. More recently, researchers at the Institute of Global Health Innovation's Hamlyn Centre at Imperial College London have gone a step further to explore how human vision can be used to control or guide surgical robots. Things like how the surgeon's eyes can be used as a 3D scanner to describe the inside of their patient in 3 dimensions and accordingly guide or restrict the actions of the robot, or visualize complex surgery in a way that's easier for the surgeon to work with and the robot to understand and assist. Our eyes can collect information about the world around us, while at the same time project so much information about our thoughts and feelings. Thinking about human vision in this bidirectional way has been important in helping us to understand when and how robots can best assist during surgery. By detecting concentration levels or by checking whether the surgeon needs to take a break, the robot can accordingly adapt its behavior and switch to a higher safety mode. We're still a long way off seeing fully autonomous robots holding a surgical knife, with many technical, legal, and ethical challenges to overcome. But as we look ahead, with more tasks being handed over to robots, it's important to consider who or what will be making the final decisions and where the ultimate responsibility lies. How confident would you feel knowing a robot surgeon was about to operate on you? Would you trust a robot surgeon?
Yeah, so that's a very fundamental question. Would you trust a robot surgeon? And the way the future is moving towards, with the use of artificial intelligence and all the other new techniques that are coming up, begs this question more and more. So you can't really leave an AI-controlled system to do the surgery autonomously. We need to keep the human in the loop of the decision-making. What we're doing here, what we're going to show today, is how we're using gaze, the human visual system, to simply control a robotic surgical instrument so it doesn't go away and does things. So we're trying to improve the ergonomics of the task. That's one thing. And the other thing we're doing through this is that how we use the eyes to collect information during a physician is doing an examination on a human being. So if something is missed, then the examination, the system can recognize this and then can suggest to this physician to go back, revisit this particular part of the anatomy, and then make sure that there is no cancer, for instance, left inside the colon or inside the stomach. And we do that by using this instrument, which is Professor Darzi touched on this earlier. He mentioned about this is the Flexible Endoscope. This is a device that has been around for about, I don't know, if I'm not mistaken, 70 years. It was first introduced back in the 1950s. What is this? It's just a tube. It's a flexible tube. And then the only control you have over this tube is this steering bit at the front, which I have to use my thumb, use these dials, rotate them, and then I have to control the front bit. The rest is performed by pushing. So you use a body's natural orifice, it can be the mouth, or it can be the anus. You insert it inside the stomach, or you insert it inside the bowel. You push forward, and then by steering it, you try to go around and see if there is any cancer. And ideally, and if it's easy to do, you can remove it in one, at the same time. Yeah? The problem with this system is that it's been around unchanged for the last 70 years. Ergonomically, it's really, really difficult to use. Long operations, complex operations, you just have to use your thumb and push it in. And if you want to remove something from the tissue, like a little piece of tissue to send it for histobiology, histopathology examination, basically a biopsy, you have to use this instrument that Kai is going to now insert inside the biopsy channel of this endoscope, like that. And then the two of us together, and maybe a third person sometimes, I have to push it in, I have to control it, I have to look on the screen, and then Kai will have to progress this little instrument at the front. I will tell him, okay, grab the tissue now. Or I have to give him control, and then we swap. He's controlling the endoscope. I ask him left, right, up and down, stop there, okay, yeah, and then I obtain the biopsy. So this is not ideal. So what we're showing here instead is that we have now motorized this flexible endoscope. As you can see, this is an identical endoscope, and we have mounted two motors, which motors are able to control the rotation, the steering of this flexible endoscope. And then Adrian is wearing a pair of eyeglasses. This is an eye tracking device. It has a camera at the front, and it has two cameras which are tracking images from the eye. And I think the AV people can bring a picture-in-picture up there so we can see it better. If I disconnect, yeah. There you go. Okay? So what we're going to show you now if Kaitse can, I will step down so I'll make way for them. So the eye tracker, as you can see on the screen up there, has a scene camera at the front. So there is a camera here which is showing what is on the screen. This screen is showing the image from the endoscope, which currently is inserted inside the simulated stomach. The task here is to use gaze information so we can tell where Adrian is looking with respect to the screen, and by moving his eyes around, he's able to control the position of the endoscope in a hands-free fashion. So basically, he can let it go, and he's able with the eyes to control the endoscope, and then go to do the biopsy alone. No second or third helper needed, and also, this gives us the opportunity to understand where the Adrian or the physician has actually looked on all the areas inside the stomach. Can we simulate this? Can we show this, please? So what Kai is doing now is a very fundamental step. He's calibrating the eye tracker by asking Adrian to look into this moving target. This moving target gets tracked by the computer, as you can see on the screen. And then when the calibration finishes, then the red dot that you see on your screen, which is the fixation of Adrian, will correspond to the exact position where actually he's looking at. So this is specific to each user. So each physician, before they start the operation, they do the calibration once, and that's it. So if I put my finger out there and ask Adrian to follow it, you can see the red dot is right on my finger. So the system is calibrated and accurate. So the next thing to do is switch on the motors. Yeah, a bit of a Python code there, quite low level. You don't want a clinician to be able to understand any of these things. You want to keep it as transparent and as high level as possible. But as you understand, this is research at the moment. When in fact, this system now, we are about to test it in real patients at St. Mary's Hospital. So what you see now, Adrian, he's not doing anything. He's using his eyes to control the endoscope. And then when he reaches a target, he stops. His fixation point goes on the center of the screen. He inserts the instrument, picks up the tissue, and that's it. Okay, so that was a very brief and simplistic, in a way, demonstration of the things we were doing. Hopefully, gave us a flavor, gave you a flavor of what we're doing. And yeah, there's so many more things we can do. And yeah, thank you very much for your time. Thank you, yeah, I hand over to my colleague, Kushi.
Yes, hi guys, I'm Kushi Vyas. I'm one of the postdocs at the Hamlyn Centre. And today I'll be showing you some of my work on fiber-based endomicroscopy probes and how they aid for tissue diagnosis inside the body. Sorry, bear with me for 1 second. So what we have here in the demo is a very small portable endomicroscope that we have developed, and we have connected it to a flexible fiber device like this. Now, this fiber is a collection of 30,000, this is a fiber bundle, which is a collection of 30,000 fibers. And it has a lens assembly at the tip, which is a 5-lens assembly. What it helps us to do is it helps us to take tissue images from inside the body. Wherever it touches, we can get a real-time histology-like image. In my demo here, I'm going to show you a few objects which we scan and how we can see very small details of those objects. And at the end, we'll do some sort of an interactive session where I'll show you an image, and then I'll have you all guess what that object you think that is. The program for this is very simple. We adjust the exposure for the fiber, which detects how well we get the contrast on the camera. And I can put it on my tissue. It would be very similar to scanning tissue surface inside the body. So here I have a C sponge. We can enhance the view, like scale the image up to see and have a better higher magnification view. And as I'm putting my fiber on the sponge, we can see very thin thread-like structures. So those are actually the very fine threads of the sponge. What you see in the earlier demos, for example, the endoscope that we have here, these endoscopes have a working channel, which is like a hollow channel through which surgical tools can pass through. We can also pass these kind of flexible microscopes through it. And the advantage, I'll explain, the advantage of what these devices are. So the endoscopes, they have a camera and a light source, which basically help us to see organs inside the body and guide the surgeons as to where they want to go and to know what they are cutting. The resolution, that is the size of the smallest object we can see effortlessly with these endoscopes, that is around 200 microns, which is a little bit lower than what we can see through our eyes, but through our eyes as well, naked eyes, we can see comfortably around 100 microns. So if we really want to detect cancer or any inflammation or disease in the body, we want to look at the cells, their architecture, their changes. And size of a normal cell and the nuclei within it is around 1 to 10 microns. So if we really want to detect these tiny cells and the cancer and its marches inside the body, we need a much higher resolution microscope to do it. I'm very sure in school everyone would have played with benchtop microscopes, imaged onion skin or cells inside. But if we want to do it inside the body, we need to have a tool like this fiber bundle that can go in either through our mouth or through the working channel. And then in real time, wherever it touches, it should give us a very high resolution image of that tissue. So that is what we are trying to show here. We have used this for a lot of experiments now in human tissue, where we imaged breast cancer margins and urology tissue. And the idea is to be able to give the surgeon a much higher resolution histopathology-like device. So you can see the cancer cells and cancer margins inside patient and make a diagnosis accordingly. So what we see here for the sponge are also like the thickness of these hair-like structures, fiber-like structures you see. It is around, the thickness is around 10 microns. And we can see them individually as I'm scanning over my tissue. So I'm gently moving my probe across this surface, and I'm able to see this. Interestingly, if we want to see how our skin looks, a very easy test for it is to use a fluorescent marker. And I'm just going to put some on my skin near my nails, because that's where a lot of dead cells, skin dead cells are. And mimicking how a sheath would be, I'm just going to put some plastic around my finger. And then as I put the fiber on there, I'm expecting to see some of the skin cells. Now here we can see some of it is very oversaturated. We can quite easily change the contrast and see if we can get a better looking image. So the application of these kind of systems it aids the surgeon to not only look at the general structure of the organ, but also to see some cellular features, which are quite important to, when we are detecting margins, especially for cancer tissue. So we could see some of the skin cells. The resolution of this device is not as high as we would like, but for demonstration purposes, we have used an LED-based device. In principle, we use a laser-based confocal microscope, which helps us to get a much higher contrast image. And lastly, for the fun part of the session, I'm going to just scan a bit on something, and you can guess and tell me what do you think that is. So I'm going to lower the exposure slightly, a bit more. So what do you think this is? Anybody? Sorry? Yes, but it's not the normal paper we see. These are the threads of a very thin tissue paper. If you look at the normal paper, it would be more gray, more dense, whereas this, I think the threads are around 1 micron or 2 micron thickness. And what you can also see are layers of threads, one above the other. So if you look at your skin, you have the top epidermis. You have some cells, myocells below it. So it helps us to see and kind of do some sort of optical sectioning to see what layers we are seeing, what changes potentially are there, and if the cancer is in the epithelial region or slightly lower. So that is all from my end. We also have several, like my PhD work was mainly to build these endomicroscopes, and now I'm leading the endomicroscopy-related research and the translational part of it in clinic. So we do have several flexible endoscopes, like you can bend it, some which are thinner, some which are larger. So it depends on the application. A lot of research, like Prof. Darzi was saying, is going on with robotic, in coordination with robotic engineers to integrate this in clinical practice, where we can manually scan or use a robotic scanner to scan it, like George was saying. So thank you all for listening. And I'll be around in case if you have more questions. Thank you.
Let's have another speakers and demonstrators today. This session's been so jam-packed full of information, but unfortunately that means we don't have time for a Q&A, an audience Q&A. However, some of our speakers are going to stay around, so feel free to ask questions. Also, you can ask questions on social media. You can see on the banner here, it's at EXRD Festival on Twitter, at Exhibition Road Festival. So there are lots of venues to get your questions out, and that goes for you at home as well. So one last round of applause for our speakers, and thank you for coming.